do you want to start by giving us a quick intro about who you are and kind of some of the research that you're involved with?
Sure. So I guess I start saying my name. So my name is Malpica. I'm originally from Peru, did my medical training in Lima, and then in 2014 moved to Miami to do my internal medicine residency for 3 years, and then my Hemong fellowship in 2017. Then I was able to get a faculty position in the University of Texas MD Anderson in Houston in October 2020, and since then I've been part of the faculty for the lymphoma and myeloma department, and it was I believe in mid of 2021 when I had the pleasure of meeting you and the Chike Springer Foundation, and since then, and I'm sure we're gonna chat about that here today. Many things has happened, which I'm very excited to update you with.
Yeah, that's awesome. Yeah, we were so happy to meet you working with our partners with the Lymphoma Research Foundation to be able to sponsor you with the Chike Legacy Scholarship. That's great, and connect you to the LRF network. That's amazing. Can you tell us a little bit more about why you're interested in lymphoma or cancer in general?
So I have to say that when I was in Peru, my first training was in infectious diseases, and it actually is very important for me to mention that, because one of the specific diseases that I have a lot of interest on is actually a viral mediated disease. It's also called as adult T-cell leukemia lymphoma. And the reason why I got so interested in that is because, unfortunately, this environmental factor like viral infections and things like that affect people living in less developed areas, and perhaps what we call minority groups. So my focus was basically based on how we can change the outcomes of patients living with less resources and having like limited access to healthcare. So that was where my interest is come from. The same thing happened when I joined residence in Miami, because I was working in a university community hospital, and we work a lot with uninsured patients, and many of those actually have the disease that I just referred to, which is a rare lymphoma, and has a very poor outcomes. So there is other rare lymphomas which I got interested on, but in general, the reason why I got so interested in lymphoma is because those are one of the diseases in which we believe we can do more, and we know that our lymphoid system. Name is shown a cliche, but that's what actually leads all our responses against cancer, against infection. So we all need our lymphoid system. It's just that when this get out of control, the nice thing is that we can always get it back to work again normally. And many times we're able to cure the majority of cases. And since the last decade, we started with few drugs being approved every year, but now it's been just skyrocket, and we have many therapies that we can try that maybe was not available, unfortunately, for our patients in the past, but now we're very proud to say that we have moved the field of lymphoma significantly.
Yeah, absolutely. One of the things that I always found very interesting is how many different treatment options there were for aggressive lymphoma, which is the kind that Chike had. And it was very interesting to me because there was a lot of options, but not necessarily after the first line of treatment failed, not necessarily like a next best option. So kind of what you were saying, some groups of people are very under-researched and understudied as far as the impacts to specific treatments to that group. And that was something that Chike was extremely interested in because he was a healthy young male. And his labs and all of, everything, every time the doctors came to talk to him, he thought, I feel okay. Like I feel fine. And they were just like, no, you're not fine. Your levels are off the chart. Your liver is in horrible shape and things like that. So he really thought, treatment should be more tailored to him. And with the new advances, we began studying all the new advances with precision medicine. So he just became very interested in specific treatment and kind of looking into those deeper levels, like you said, and making those options even better, and making more cures, even though lymphoma does, like you said, have a high cure rate. Why do you think there is such a gap for some of those underserved populations, specifically people of color, and even young adults are understudied groups? And why do you think there's like that gap of not only treatment availability, but treatment outcomes as well?
I very much like your question, Lyndsay. So I think there's two ways to see this. The first one is how the sponsors, which is many times the companies who make these novel drugs or compounds, how do they see the field of hematology and specifically of lymphoma? So what we have learned is that sometimes when we want to enroll patients, we have to check many boxes. And sometimes some of those boxes is like how much access you have to healthcare, how much of a caregiver you have that's going to be with you 24/7, how much commitment you can have, like getting transportation from the house to the hospital, getting parking, who can really assist you with that. And we all know that many of our patients who come from underserved communities, they have those limitations. And believe it or not, they do not disqualify from the trial because of that disease, but they do disqualify from the trial because of the other components. And the question comes here is that if that really is a fair assessment of how we should be enrolling patients. And that's what actually that controversy comes. And we know the racial disparity happens. We know that we have more African Americans with less socioeconomic status compared to Caucasians. The same thing happened with Hispanic, and I guess in a less amount in Asian Americans, but still there's a big community also that is affected by this. So one of the goals that I have in my research is trying to see how we can make this criteria a little bit more flexible based, as you clearly said, on the individual rather than the disease. So I think that we have still a lot to do with that, but I think that's a big factor why that thing happens. And the second thing is that we all know that there is outcomes differ based on race and ethnicity. Just to give you an example, these aggressive T-cell lymphoma that sometimes we see are commonly seen in Hispanic and Asian patients, and are rarely seen in other populations. But at the same time, for example, other cancer like breast cancer, we know that these, what we call triple negative breast cancer, which are the most aggressive one, those are most commonly seen in African Americans. And that's what deaths from breast cancer comes in this population. So it's not just also a disparity problem based on socioeconomic and healthcare access, but also biologically they are different. And it makes sense to be different. We are all different. So the problem is that even though we know that the data tells you this is different, no one really can look that into detail. So that's what we are proposing to do. It's like for first time, or at least to start seeing the differences in an objective perspective, mainly, more than really trying to do some suggestions based on what you've seen. So that's what the goal at the end is going to be.
You know, one of the things that we always say at the Chike Springer Foundation is we don't necessarily need more research, we need better research. And I think exactly what you said, that really resonates with us, because that was something that we saw, you know, going through the multiple treatments that Chike went through. He went through over 7 different treatments, including one clinical trial at NIH. And there were just issues and, you know, trying to make him fit into that clinical trial was very difficult, when clearly some of the things like keeping him off treatment for a certain number of weeks was detrimental to his health, but he had to do it to get on the trial, and things like that that are hard, that help with the science, but don't necessarily help the patient. I would also like to ask you if you had any other ideas to kind of improve clinical research design and some of the other things that you've been thinking about.
The field is trying to shift right now to something that we call, so I guess I'm going to give first an overall perspective. Many of these trials sometimes are focused on what we call response rates. So response rates, which you may familiar with, Lyndsay, means like either you achieve a complete response, meaning like everything is gone. You achieve a partial response, which means like I know everything is gone, but something is left. Perhaps maybe half of that is left. Or a stable disease, which many times is just, okay, you cannot go, you cannot make that disease to go away, but you can kind of keep it quiet. So many times, most of, I would say, clinical trialists, including myself, we feel like that has to be the end goal. But in the recent years, we start thinking like, it is that really the right way to see? And then something comes out that we call patient-related outcomes. So patient-related outcomes is like asking the patient, okay, from your cancer, we know we cannot treat it. What's your main symptom? Many times it's just pain. Many times it's just itching. Many times they just cannot eat, or many times they're just very fatigued. So now we are trying to implement all these patient-related outcomes to all trials, because at the end, if the treatment goes with a lot of toxicity, and it's true, you can make the lymphoma go away, what happens with whatever is left from what you have done? So in the case of Hodgkin, for example, which I'm sure you're familiar too with that, is that affects many of our active citizens. I hope it doesn't sound funny, but this is the population that makes all the taxes because they are in the plenty of their life, looking for a job, and being productive in society, and then this disease happens. So it affects this patient population, and it doesn't really affect just because of the disease, but everything that comes in there, that their families, if they have kids, their kids, because many of them are usually children. So all these are patient-related outcomes, because that's what you have to ask the patient is in which levels the disease has affected you, despite from that. So we're kind of moving away from just focusing in the response, but also what else is that we can do better. For Hodgkin, always a big dilemma has been, is radiation really necessary? Because sometimes we cure these lymphomas and then 20 years later, when patients are 40, under 50, they're having a severe heart attack or requiring like a change of one of the valves in the heart to make it work better. So I think like we are heading into a non-chemotherapy approach, but at the same time, a less toxic approach if ultimately we have to do it. So we have a lot of work to do, but I would say the patient-related outcomes is something that most trialists right now are trying to focus, because at the end of the day is how patients feel and how they feel that the disease is being managed, as you clearly said.
Yeah, I absolutely love that because, going through it personally, you might read the studies and exactly what you're saying, they have the stable disease percentage, they have the complete response and the overall response percentages. And it's like, you think, what does that really mean? Especially when you're talking about a human life, it's not just, did you get past the next year? What's your life going to look like in 5-10 years? Are you going to be able to have kids? Are you going to have lasting impacts from the treatment? Are you going to have some kind of mental issues from being in the hospital so long? There's just so much that affects the patient and their family members that I'm just really glad that it's becoming part of the research and part of the thought process as far as what treatment options are available and kind of what's the end goal here, not just did they respond in a year and did they still, is cancer gone? Because as there's a ton of not relapse, but what is it called when basically they get another cancer maybe a couple years down the road with lymphomas especially. So yeah, do you want to talk on that a little bit on some of those kind of impacts?
Part of the research we are proposing with the foundation is basically to study what we call secondary malignancies. So many of these young patients, which have Hodgkin lymphoma, for instance, we are trying every time to de-intensify, go down in the dose and the intensity of the treatment. Because what we see is that 20, 30 years later, they develop either leukemia, or if they were women getting radiation, they get breast cancer from there. Or they get secondary sarcomas from the radiation, or as I said before, even maybe no secondary cancers, but cardiovascular disease or something. So that's the reason a lot of the trials now for Hodgkin, unfortunately for Chike maybe wasn't an option at that time, but now we're trying to use immunotherapy, which is really a non-chemotherapy or a chemotherapy-free approach. And I think we're doing a very good progress. The only thing is that, as you know, sometimes in these diseases, the first thing the physician tells you when you go to the office is, "Oh, you're good. You have one of these diseases we're going to cure." But there is always a handful amount of patients that's not, they don't fit that part. So part of our research is also to study why these patients' tumor didn't respond to what we think was the normal pattern of treatment. And I think there is still an unmet need of trying to understand better why we have these exceptional responders, why we have non-exceptional responders. So even though there are many variables, I think we're still kind of trying to lean into individualizing treatment, as you clearly said at the beginning of this talk. But yes, I think like one of the main things that we're going to focus right is trying to get the less toxic and possibly non-chemotherapy free treatment, so that way we can not only cure patients, but perhaps prevent them from having complications in the future.
Yeah, I love that. That's amazing. That mindset is so different even from, 10, 15 years ago when you read back through medical studies. I absolutely think that's amazing. That's something that when we looked at starting the foundation and focusing on research, what we wanted to bring to the table as far as, not just supporting another research study, but supporting somebody that has that vision, that has that comprehensive look. When you're a part of a clinical trial and witnessing it as a caregiver, you realize how many data points are missed because your person, you're thinking all these different things that are special about that person that might make things different. And unfortunately, medicine today doesn't necessarily look at an individual that in that much detail. So we really advocate for what I call the deep research approach. And I've even looked at using artificial intelligence or machine learning to really individualize medicine. And I know that's where where everything's going. So we're definitely always looking for opportunities to support that and fund that type of research as well.
I think like the cornerstone of that at the end of the day is collaboration. So most of the things that we do, just to give you an example, MD Anderson is a good cancer center, not because they have bright physicians. I mean, they do have very caring, smart people, but it's the institution, it's the fact that patients go there and then we are able to learn from the patients and we're able to learn from their disease. So the expertise is built based on that, because our patient volume will be low. It will be hard for really learn from rare diseases. Same as the NIH. They are recognized because they see every kind of disease. So at the end of the day, when I say we, means like physicians and patients, we both learn each other. And at the end of the day, for example, for my patients, I want them to be the most educated and knowledgeable in their disease. So they understand what we're going through and why we're doing certain treatments. But you are correct. I think like at the end of the day, we all gonna have to look the same outcome. And I'm very appreciative that foundation like yours under your leadership are looking to trying to improve care from all visions, from having, of course, the cure, which was what we all want, but at the same time, preserving their lives quality, making sure that they can have a fulfilling life after the cancer, because at the end of the day, that's what they want. They just want to go back to society, to their families, and do their duties as they wanted to do it before they were cancer even being diagnosed.
Yeah, absolutely. And I can personally say that's 100% accurate. You're always looking at what can you do after the disease. And that is exactly why we started this foundation, because that was Chike's vision. He never, even when treatment wasn't working for him, he never thought, okay, well, let me just focus on me for now. He always thought, okay, the doctors have it, we'll figure out the treatment. And after treatment, I think I should do this, and I should use my story, and I should, inspire others, and I should, help other people have a positive attitude. And that was really big for him, which is why we had so much motivation and inspiration for the foundation. So just really great talking to you and kind of being reminded of some of those those thoughts and some of those visions, because it's, you know, exactly what Chike would have wanted as well. What do you think is one of the reasons why you've been so successful? You're a junior investigator, but you have, you know, a lot of publications to your name. You've been very successful, and I know you're going to continue, you know, being successful and making huge breakthroughs for lymphoma. But what do you think is some of the things that attribute to that success?
Well, thank you for the kind words. I'm still learning, and I will continue to learn, I'm sure, until I retire. And that's going to be always an ongoing process, especially in academia. So I'll say that a lot of that success has to be with the people that I came across with during my career. And that goes from the very beginnings when I was even in med school, having my mentors from Peru, always encouraging me that I should try to do something overseas. You know, there is always these people that see some potential in you, even if you don't believe it in yourself. But they say, like, I know you can do it, go through. I guess the first people that you came across with that are your parents. So they always encourage you. But then there is always people at work that kind of have the same vision as they do. So to me, I think even in the position I'm right now, it's a lot have to do with these mentors that I was able to have in every single stage of my career, since I was a resident with Dr. Juan Ramos in Miami, when I was in UNC with Dr. Paul Armistead, who actually was a fellow in MD Anderson. They moved to the University of North Carolina. And most recently, Dr. Christopher Flowers, who is right now actually the chairman of the department, but who has a plenty of expertise mentoring people. But not only that, mentoring people of minority backgrounds. So he knew my limitations. He knew about the things that I didn't know, because not because I didn't want to know, it's because I didn't have a PhD degree. I didn't have like a public health degree, but he knew the potential was there, and then and the trust based on that, and start saying, I think we can do things differently. So I would say that if anything, everyone needs is someone to mentor you, someone to guide you about how to do. And I think that even happens in life. I mean, no one can tell me that everyone that comes to this country, I didn't even know how to do my taxes. So I have to find someone to help me how to do it. So I think in life, you need someone to bring you guidance. And sometimes you have to be self-taught in some things, but if things get easier and perhaps even brighter and more successful, you have someone that is always giving you feedback in real time. And that's what has happened to me all the time. You know, I always had this mentor that even if it was a weekend or something, they were with me writing a paper or writing a protocol or writing a new idea about a grant. So yeah, I think if anything we can also do for the newer investigators is to have a very good mentorship program for them, because I think that will make the difference for me.
Yeah, I think that's amazing. You already know that Chike was, and the Chike Springer Foundation, we believe in mentorship and really supporting kids from a young age. Our mentorship program is going to be geared towards high school students and really pulling them up through the undergrad and into medical research, whether that's medical school, data scientist, becoming a data scientist, becoming a systems biologist, becoming a nurse, those types of things. We really want to inspire young kids and inspire high schoolers. And you're going to be a part of that with us. And we very much thank you because we're just right now, this year will be the first year that we start setting up the program and working with some partners in DC to get into those schools and kind of developing that program. So we're very excited to do that because same as you, we believe in mentorship and we believe how important that is for everyone's success at all different levels. What advice would you give high school students or younger students who are interested in studying cancer and interested in the medicine field?
That's a good question. I guess we all humans are motivated for something. Like you are motivated for chicken, and that's what's the reason you're doing all this. I was motivated because I had a hard life, and I wanted to strive. I wanted to do something better, including my family. So I would strongly say to these kids, do not give up. You're going to have a lot of struggles. That's going to happen. life is not straight. When I was in medicine, you learn during classes that you should not transfer your feelings to your patients. But I always thought that was not right. And I tried it throughout my career until I'm oncologist and a faculty. Well, it's impossible not to have the feelings for your patients. I mean, they are your friends at the end of the day. So for all of you that are gonna be listening to this, is just pursue your dreams. I mean, there's nothing is gonna be easy for anyone. Have faith on what you do. A lot of that also have to do with your family. Sometimes we don't have that support, and that sometimes happens, especially in certain groups. Like my parents were living 24 hours away when I was just living with my brothers. So it was a challenge because you have to prepare them for school, but then you have to also study. So you all are not alone. I mean, we are all in the same place. We are all have the capabilities to do it. And I think programs that the ones that you're leading, by having an extra support, that I think makes the difference. So to everyone that I think wants to do a career in science, just think about what is the one thing that you want to change. What is the one thing you want to make a difference? Even if that make a difference means just to discover one single protein that will take your entire life. For me, my one single thing is to try to get access to these therapies to people that really need it, and to try to be flexible for those that cannot get access to. And I know this is going to be my career path, and I'm very aware it's going to take me years, but I know that this is the way we change history, and that's been proved. So we think we can make a difference if we just continue pursuing your dreams, even if you encounter a lot of difficulties, which we all gonna have. Nothing is that straight in life, and I think like you just have to keep pushing. There is no other way, but we also are gonna be here for you, and we also gonna be more than happy to go through all this if we are able to help, and I'm sure we will be able to. So just keep fighting. That's my main advice for them.
Wow, that's beautiful. Yeah, I mean, keep going, and at the foundation, we say together we can overcome, keep going. I love all that. That's very positive. It's been amazing talking to you. Thank you so much for your time. Dr. Malpica, you're doing incredible things. And I know you're going to keep continuing to do incredible things, and we're so happy to support you. And we'll keep in touch. We'll keep our followers in touch with everything that you're doing, all the amazing work that you're doing. But thank you so much for your time.
Oh, thank you, Lyndsay, and keep the hard work, please. We need more people like you and people in that foundation. We definitely need all these bright young investigators to be out there, because we are in a diverse society. Every time we are evolving, and I know at some point we're gonna make cancer history. I mean, I think that's gonna happen. And so, thank you very much for this conversation and for allowing me the time as well to share all this with you. Thank you.